Hello, everyone. My name is Oveen Joseph, and I'll be presenting on behalf of Manica, and we're going to be going through this PowerPoint on understanding postpartum depression as a comprehensive overview of symptoms, causes, and interventions. Welcoming a new baby is often considered one of life's most joyful and meaningful experiences, marking the beginning of a crucial bonding period between mother and child. And for many women, this stage is highly anticipated and emotionally rewarding. However, not all mothers experience this transition positively. For some, the postpartum period is complicated by significant emotional and psychological difficulties. Postpartum depression is a serious and legitimate health condition that can affect women after childbirth, impacting their well being and their ability to fully engage in early motherhood. So, welcome to this presentation on PPD. The objective today is to deepen your understanding of postpartum depression, or PPD, through a detailed review of its clinical features, contributing factors, dissecting some of the at risk populations, and the various treatment approaches. This knowledge is essential for anyone, especially new mothers or supporting someone through the postpartum period. We'll be going over some of the learning objectives for this presentation, starting with learners will define postpartum depression and distinguish it from normal postpartum emotional changes like the baby blues and more severe conditions such as postpartum psychosis. They will be able to explain the global prevalence of PPD and understand its public health significance, focusing on how it affects mothers, infants, and families. They will also learn to identify classification, symptoms, and diagnostic criteria for various postpartum mood disorders, including mild, moderate, and severe cases. Learners will analyze the causes of PPD, examining biological, psychological, and social influences. They will be trained to recognize key risk factors and identify vulnerable populations such as first-time mothers and those with limited support or a history of mental illness. Finally, they'll evaluate different treatment options, including medications, psychotherapy, and community-based support strategies. Here's a quick table of contents of everything we will be going over today, and we'll jump right into defining postpartum depression. Postpartum depression is a significant mental health issue that extends beyond typical emotional changes associated with childbirth. It involves a combination of psychological, emotional, and physical symptoms that interfere with a mother's ability to care for herself and her baby. It's important to distinguish postpartum depression from normal postpartum adjustments, as timely treatment can dramatically improve outcomes. It's a mood disorder that occurs after childbirth, and it usually develops within the first 4 to 6 weeks postpartum, but it can appear anytime within that first year. And it's more than just feeling sad. It affects mood, behavior, physical health, and also mother-infant bonding. Next, we'll be going over the prevalence and public health impact of postpartum depression. PPD is not a rare condition. It's a growing global health concern. In the US, around 14%, or 1 in 7 women, experience postpartum depression, and the actual numbers may be higher due to underreporting. On a global scale, the prevalence ranges between 10 and 20%, and in lower resource settings, rates can exceed above 30% due to limited access to care, cultural stigma, and lack of screening. And despite its high prevalence, postpartum depression often goes undiagnosed, which underscores the need for broader awareness, policy development, and improved maternal mental health care systems worldwide. Next, we'll be going over classifications and key symptoms of PPD. So there are 3 main categories of postpartum mood disorders, which include the baby blues, postpartum depression, and postpartum psychosis, and each differ in their severity and require treatment. So while some symptoms like fatigue or mood swings may seem common in early motherhood, their duration, intensity, and impact on functioning help determine if a clinical disorder is present. So some of the common symptoms seen in PPD are persistent sadness, fatigue, and irritability, sleep disturbances, and difficulty bonding with the baby, and also thoughts of self-harm. We're going to start off by unpacking the baby blues, or mild emotional shifts. The baby blues are a natural reaction to hormonal shifts and the exhaustion of early motherhood. These feelings are usually mild and transient and don't require medical intervention. However, persistent or worsening symptoms beyond 2 weeks can indicate the onset of postpartum depression. It's very common. Up to 80% of mothers experience the baby blues post-delivery, and some of those symptoms include mood swings, crying spells, anxiety, and feeling overwhelmed. The onset is typically between 2 and 3 days post-delivery, and it usually resolves within 10 to 14 days. Next, we'll unpack clinical postpartum depression. Postpartum depression can significantly impair functioning, and mothers may feel detached from their baby, hopeless, or even fearful of being alone with the child. The emotional pain can be compounded by shame or fear of judgment, and recognizing these symptoms and providing appropriate support is key to recovery. It affects approximately 1 in 7 new mothers and can develop gradually or suddenly. Symptoms include persistent low mood, anxiety, guilt, a loss of interest in activities, difficulty concentrating or making decisions, and even suicidal ideation in severe cases. Next, we'll be unpacking postpartum psychosis, which is an acute psychiatric condition, and it is a psychiatric emergency. It can escalate quickly and puts both the mother and baby at risk. Women with a history of bipolar disorder or previous psychosis are at highest risk. Immediate hospitalization is essential for safety and stabilization. It is rare, approximately 1 in 1,000 deliveries result in postpartum psychosis, and it is very serious. The onset is rapid, often within 48 to 72 hours post delivery. The symptoms associated with postpartum psychosis include delusions or hallucinations, confusion or disorientation, mania or severe agitation, and even suicidal or infanticidal thoughts. Next, we're going to do an overview of the underlying causes and contributing factors of PPD before we dive into specifics of those causes. It's important to note that PPD is of multifactorial origin, meaning it comes from a lot of different places. There's no single cause for it, and it develops from this complex interaction of biological, psychological, and environmental elements. Some of the biological factors include sudden hormonal shifts of estrogen, progesterone, cortisol, and thyroid hormones, neurotransmitter imbalances such as serotonin, dopamine, and GABA, and also genetic predispositions to mood disorders. Some psychological contributors include history of trauma or adverse childhood experiences, or ACEs. Low self-esteem, perfectionism, or negative thinking patterns can also increase risk, and also a fear of inadequacy or failure as a parent. Environmental and social factors also play a role in risk for PPD. Lack of emotional or practical support, financial strain or housing instability, and even cultural stigma around mental illness or motherhood can contribute to risk. And it's very, very important to note that postpartum depression is not caused by personal weakness, poor character, or lack of love for one's child. Um, Again, there's no single cause for PPD. It's just the result of convergent factors, including biological vulnerability, stressful life events, and a lack of support. And it's important to reduce stigma by reinforcing that postpartum depression is a medical condition, not a sign of poor parenting or emotional weakness. Biologically, a woman's body undergoes dramatic hormonal changes after childbirth. Estrogen and progesterone levels, which are elevated during pregnancy, drop sharply post-delivery. These changes can influence brain chemistry and mood regulation. Additionally, some women may have imbalances in neurotransmitters like serotonin or dopamine, making them more vulnerable to depression. A family history of mental illness or genetic predisposition also raises risk. The psychological burden of new motherhood can be intense. Many women feel overwhelmed by the responsibilities and experience a sense of identity loss. Sleep deprivation alone can impair emotional regulation, and traumatic or unplanned births can compound feelings of helplessness. Support from a partner, family, or community plays a protective role. When the support is absent, mothers are more vulnerable to stress and depressive symptoms. Social isolation, especially in modern parenting contexts, can severely affect recovery. Women with a personal or family history of mood disorders have an increased risk of postpartum depression, and this includes women who have previously experienced depressive episodes or have been diagnosed with anxiety, PTSD, or bipolar disorder. Screening for mental health history during prenatal care is crucial. New mothers often compare themselves to unrealistic ideals portrayed in media or their own upbringing. This can fuel a cycle of guilt, shame, and negative self-talk, all of which contribute to or worsen depressive symptoms. Research shows a genetic component to mood disorders, including postpartum depression. If a mother has a sibling or parent with depression, her own risk increases. Genetic susceptibility doesn't guarantee PPD, but can influence how she reacts to hormonal and emotional stressors. Complications during birth or postpartum recovery can be physically and emotionally taxing. When the birth experience is traumatic or the infant has health concerns, mothers may feel fear, guilt, or grief, increasing vulnerability to PPD. External life stressors can magnify the emotional burden of new motherhood. Major changes like moving, losing income, or marital issues can overwhelm emotional reserves and disrupt social support systems. It is important to emphasize that postpartum depression is a medical condition and not a moral failing. It does not mean a woman is weak, ungrateful, or a bad mother. This message is crucial for reducing stigma and encouraging timely treatment. Next, we'll be going over recognizing and diagnosing postpartum depression. Diagnosis is based on the severity and duration of symptoms. So, if you have symptoms lasting longer than 2 weeks and they're causing functional impairment in daily life, red flags should be going up and we should be thinking about PPD. Some screening tools we can use for early detection and are effective for early detection is the Edinburgh Postnatal Depression Scale, or EPDS, and also the PHQ-9, which is a depression screening tool. Involvement of obstetricians, pediatricians, and mental health professionals are crucial, and it's important for these healthcare professionals ask about mental health during routine postpartum visits. Next, we'll be going over risk factors and vulnerable populations. Certain populations are more vulnerable to postpartum depression due to socioeconomic, medical, or cultural risk factors. For example, teenagers or unintended pregnancies, multiple births, having twins or triplets, domestic violence or a lack of safe housing, and a minority status and healthcare disparities all increase risk factors for PPD. Clinicians must take an inclusive approach, recognizing how systemic issues can affect maternal mental health outcomes. Next, we'll be going over approaches to treatment and care. Treatment depends on symptom severity. SSRIs such as sertraline or fluoxetine are the most commonly used medications and are often safe for breastfeeding. SNRIs such as venlafaxine can be also used, and new therapies like brexanolone provide options for severe cases. Psychotherapy such as cognitive behavioral therapy or interpersonal therapy are effective and sometimes preferred by mothers concerned about medication. In psychosis or treatment-resistant cases, hospitalization and electroconvulsive therapy might be necessary. In summary, postpartum depression is a complex and multifaceted condition that requires awareness and proactive management. While the challenges are significant, effective treatment options exist, and many women recover fully with appropriate care. It is imperative for healthcare professionals and support networks to work collaboratively in identifying and addressing postpartum depression early. By fostering an environment of understanding and support, we can help mothers navigate the postpartum period more safely and confidently. To conclude, postpartum depression is not only a personal struggle, it is a significant public health issue that deserves widespread attention. Globally, millions of women are affected each year, yet too many go without help. Addressing PPD with urgency, compassion, and evidence-based care can greatly improve maternal health and child health outcomes. It is our shared responsibility across disciplines, communities, and borders to advocate for better mental health care for mothers everywhere. If you or someone you know is struggling with emotional or mental health challenges related to pregnancy or postpartum, please know you are not alone and help is available right now. The National Maternal Mental Health Hotline is a free, confidential resource available 24/7. You can call it the number listed here to talk with trained counselors who speak English, Spanish, and more than 60 other languages. They're here to support anyone experiencing mental health concerns before, during, or after pregnancy. You can also reach out to Postpartum Support International, or PSI, by calling the number listed. Leave a message and a trained volunteer will call you back to offer compassionate support and connect you with resources in your local area. Remember, if the situation feels overwhelming or urgent, the National Suicide Prevention Lifeline is there for anyone in emotional distress, not just those thinking about suicide. You can call the number listed or use their live online chat anytime, day or night. Please do not hesitate to reach out. There's a strength in seeking support, and help is always just a call or click away. Thank you so much for listening to this presentation, and I hope you were able to gain some sort of knowledge and awareness on postpartum depression. Again, thank you so much. Here are the list of references used for this presentation.